Yeah, thanks very much, Rhea, for the introduction. We work quite a bit together at the Reh-Fit Center. My name's Rob Singh. I'm one of the cardiologists over at St. B. I have a few different hats. So I work obviously at the Reh-Fit as well as the Wellness Center for cardiac rehab. I also do advanced heart failure and cardiac transplant, and I also attend the cardiac care unit at St. Boniface Hospital. Today specifically, one second here, I'm going to be talking obviously about physical inactivity, specifically whether or not it can cause heart disease. So heart disease can mean various different things. I think generally speaking to the public, it means issues with the blood vessels relating to the heart. So I'm going to talk about that as well as issues with the heart pump function. So heart failure, like I said, another one of the topics that are near and dear to me as a heart failure doctor at St. B. So for today's talk, I'm going to be talking about physical inactivity. Specifically the history of where sort of exercise came into medicine, as well as the definition or the difference between physical activity and exercise. And then again, the big topic today, obviously risks associated with being physically inactive or a couch potato in quotes. The second part of my talk, and a big part of my talk really, is the benefits of exercise in cardiac rehab. As you guys know, being members of the Reh-Fit Center, so cardiac rehab and exercise is quite important for the prevention of heart disease, specifically coronary artery disease. B, once you have heart disease, also to live healthy and to prevent from having any further events. And then C, again, as I mentioned, talking about the pump itself, looking at heart failure. The types of heart failure, defining those, as well as the benefits of exercise with those. And then finally ending off with local experiences, obviously being a talk here about the Reh-Fit Center, talking about the programs we have available here and sort of how things run specifically here for those of you who have not been to the program yet. So again, talking about the history of exercise, bringing it back to Hippocrates, the gentleman who we have an oath after when we get into medicine. So he was actually the first physician to provide written exercise prescription for a patient with, quote unquote, a disease of consumption. He was quoted to say that eating alone will actually not keep a man well, but he also must take exercise. That was back in 370 BC. Skipping ahead a few thousand years, Dr. Caleb Perry was a physician in 1799 who noted the effects of physical activity in patients who suffered from chest pain syndromes specifically, and he was noted here. One of my favorite studies going through my cardiac rehab fellowship was a study from England back in 1953. This was specifically looking at people who worked on the famous double-decker buses in London, which is pictured down here. So comparing the conductors versus the drivers. So the conductors were the people who used to take the tickets, run up and down the stairs, and be very physically active, as opposed to the drivers who'd essentially just sit there in the driver's seat behind the steering wheel and go from stop to stop. What they found essentially was that conductors actually experienced a half or 50% less incidence of CHD or cardiac heart disease, otherwise known as blockages, another form of seeing CAD, which is mentioned up here, as compared to the drivers, who are a lot more sedentary as compared to the conductors. They initially thought that this was purely because of the physical activity of running up and down the stairs, as well as taking tickets, et cetera, as opposed to sitting behind the wheel. But they found that there was also other differences, mainly the size of the drivers versus the conductors. So they looked at uniform sizes, and they found that the conductors, as compared to the drivers, had significantly smaller uniforms. This is also exhibited in the graph on the right side here. So looking at the left side here, the rate per 1,000 of any cardiac events, Looking at, again, drivers versus conductors, so drivers being in the light gray, conductors being in the dark gray. As you can see, rate per thousand in the active versus inactive. When you get into the higher rates here, you can see that the drivers definitely had a lot more events as compared to the conductors. This study, as I'll show you in the next slide as well, also looked at other people who had more sedentary jobs as compared to people who have more active jobs. So the second part of this slide right here is just looking at people who are essentially telephone operators, i.e. people with inactive jobs, as compared to those who were active, i.e. postmen who or mailmen. Who are walking quite a bit. And as you can see here, people who are inactive on the left side had significantly more incidence of cardiac events, angina, as well as coronary heart disease, as compared to those who had less active jobs. This again is from the same study, so looking at people with heavy or manual labor as compared to those who have more desk or more sedentary jobs. Again, on the left side of the graph here, you have the death rate per million of cases. On the x-axis, basically heavy versus light workers. As you can see, in terms of the death rate, the light workers definitely have an increased rate of death as compared to those who have a more heavy or more strenuous job detail. And then again, this was from studies back in the 1940s. Getting a little bit more into the terminology. So physical activity does not necessarily mean exercise. So being born and bred in Canada here, obviously we know about curling and sweeping. So, I mean, there's a lot of times where patients will come into my office and say they're quite, physically fit because they can take on tasks of daily living, i.e. sweeping, as you see this gentleman on the left side. That's quite different as compared to the gentlemen on the right side, which are sweeping hard as compared to those sweeping hard, which are the non-curlers, of course. So in terms of definitions, physical activity essentially is any body movement with any sort of energy expenditure above the basal level, i.e. anything above just sort of sitting or lying, breathing. So this means anything within your work, household chores, leisure time, or fun activities, as well as walking back and forth to the bus or to your car, whatever you have in place. Exercise, as opposed to this, is actually planned and structured activity, repetitive movements, and purposeful physical activity for the sole purpose of achieving fitness. So talking about pandemics, obviously we've heard about COVID-19. Physical inactivity has been actually labeled as one of the major pandemics of the current times. It's been noted that 1 out of 5 adults worldwide are actually physically inactive. Specifically looking at where this is more common, developed countries, so first world, quote unquote, countries, more common in females as opposed to males, also more common in elderly patients due to increased comorbidities, as well as those with lower socioeconomic status or income. In terms of our neighbors down to the south, about 25% or 1/4 of American adults are known to have a profession or a general day-to-day life, which causes them to sit for greater than 8 hours per day. Looking at us specifically as Canadians, only about 15 or 16% of Canadian adults are getting the current recommended prescription for activity, which is about 150 minutes of moderate paced activity, which is current recommendations for the Canadian Cardiovascular Society. Again, moving forward, as can be seen by this picture here, this Facebook Periscope, with social media, technology advances, etc., the percentage of time being sedentary is only increasing as we go forward. And these are all numbers from a 2011 study. So looking at Homer Simpson, the quintessential gentleman who represents inactivity, is it deleterious to your health to become a couch potato? Yes, a resounding yes, from many studies, and the most recent one being from 2015. So this is from what we call a meta-analysis, basically looking at numerous different studies and thousands of different patients being followed for upwards of 20 years, at least for this study here in 2015, which was done by Dr. Biswas and colleagues. So basically looking at prolonged sitting, i.e. another surrogate for sedentary lifestyle or inactivity. So what this study found, aside from what we're talking about today, but prolonged sitting actually increases your risk of cancer. And I'll talk about this a little bit more on the next slide. Cancer being the #1 cause of mortality and morbidity worldwide. Also, once people have cancer, prolonged sitting also was found to have a 17% increase in cancer-related mortality in those people with more of a sedentary lifestyle. Again, more geared towards a cardiovascular side of things, about a 15 to 20% increase in cardiovascular disease, as well as cardiovascular mortality in patients who are sedentary as compared to more physically active. Pretty big numbers here at the bottom here. So about a 1/4 increase or 25% increase in all-cause mortality in patients who are sedentary as compared to those who are more physically active. Risk factors wise, so one of the risk factors that I talk about in terms of developing coronary artery disease, the most important ones is type 2 diabetes. And in patients that were looked at in this study, again, tens of thousands of patients followed for about 20 years, patients who were inactive actually had a 90% increase in developing type 2 diabetes as compared to those who were more physically active. So quite staggering numbers. On the flip side, so what do we get if we are physically active? As I mentioned, in terms of death and cardiovascular disease, so there's a lower risk of premature death, lower risk of coronary artery disease or blockages within the pipes or the blood vessels that supply the blood to the heart muscle, a decreased risk of stroke or blockages to the brain vessels, as well as a decreased risk of traditional cardiac risk factors, which I'll talk about a little bit more. So a lower risk of high blood pressure or hypertension, improvement in your lipid profile or your cholesterol, as well as a lower risk of developing increased blood sugar or type 2 diabetes. Metabolic syndrome essentially is an entity that we talk about in medicine, which consists of, again, high blood pressure, high blood sugar, as well as obesity. So a lower risk of that if you are more physically active. In terms of cancer specifically, so there's been numerous studies as well as meta-analyses that have looked at cancer, specifically at the risk of colon cancer and breast cancer, and it has been found that people who are more physically active actually have a less or a lower risk of developing both of those malignancies. Again, cardiovascularly, improved cardiovascular and muscular fitness in terms of just general overall well-being. In elderly, a reduction in falls and fractures, as well as better cognitive function. And in the general population, depression. So, I mean, mental health is a big thing that we talk about quite a bit nowadays. And we know that physical activity is quite a big thing that will help with that. And unfortunately, during COVID-19, we haven't had much opportunity, especially living in Winnipeg, to engage in physical activity, and as a result, we've seen that mental health has suffered quite a bit as a result of that. Moving on to risk factors for coronary disease. So this is a slide looking at traditional risk factors. In the pink here is the non-modifiable, and the green is the modifiable risk factors. The pink, again, are things that we can't really do much about, including age, gender, genetic factors, and race. Things that we can potentially do things about, obviously smoking, physical inactivity, potentially obesity, high blood cholesterol, blood pressure, and blood sugar, which I'll be talking about right now. So specifically, hypertension is the first thing that I'll be talking about, and its relation to exercise. Hypertension is defined as high blood pressure, generally speaking, greater than 120/80, which would be considered a normal blood pressure. Anything above that, up to 129/80, would be considered elevated or borderline high blood pressure. Hypertension specifically is defined as a blood pressure of greater than 130 or over 80. over the diastolic. And then stage 2, anybody with greater than 140 millimeters of mercury in the systolic and greater than 90 millimeters in the diastolic. Why do we care about high blood pressure? So it's very common. It affects about 40% of patients, 40% of adults, worldwide, approximately 1 billion individuals overall. In addition, it's a leading cause of death and disability in the world, approximately 9.4 million deaths annually, which are attributed to hypertension in and of itself. Above that, pretty striking fact. So any increase of over 20 millimeters on the top number or 10 millimeter increase on the bottom number will actually double your risk of cardiovascular mortality overall. In terms of looking at local or Canadian stats, so about 15 million Canadians are affected with high blood pressure. 7.5 million are at risk and 7.2 million are known to have it. Males less than the age of 60, myself included, are less likely to be aware that they're living with hypertension or undiagnosed hypertension. Women over the age of 60 are less likely to get their blood pressure controlled. Children, so 1 in 50 children actually live with or at risk of hypertension for genetic causes and otherwise. Again, as I mentioned, about 25% of the population overall within Canada has hypertension. So it's a very significant thing that is seen within the general population and by our family physicians. Out of that, about 1/3 of patients don't have their blood pressure under controlled, and about 15% of those patients do not have any idea that they have high blood pressure to begin with. When you do have high blood pressure, we know for a fact that exercise specifically can improve high blood pressure. Regular cardiovascular or aerobic exercise can actually decrease your blood pressure by between 5 to 15 millimeters of mercury systolic. This is about the same as one agent or one blood pressure medication at a relatively decent dose or a moderate to high dose. Generally speaking, we don't exactly know why exercise decreases blood pressure. We have a few hypotheses. We think that the sympathetic activity, so within the neurologic system, we have the sympathetic or the fight and flight system, and then we have the parasympathetic or the relaxation system. What we think that chronic exercise or regular aerobic exercise does is decreases your sympathetic activity, i.e. decreasing your amount of circulating adrenaline, substances that causes your blood pressure, your blood vessels, to constrict and cause high blood pressure to decrease in concentration. In addition, we also feel that the endothelial function or the function of the blood vessels innately have to relax improves. So all of our blood vessels have a muscular layer that has an ability to contract and relax depending on what's going on within the body. We think that exercise chronically will decrease our factors that cause our blood vessels to constrict or cause high resistance for the heart, and also increase our factors that will cause our blood vessels to relax or help the heart pump out blood. This has also been shown in autopsy studies or muscular biopsy studies that have shown that there's blood levels of thromboxane, blood vasoconstrictor, or a constrictor of blood vessels that are decreased, and increased levels of prostacyclin, a substance that we know that dilates and decreases the resistance to the heart pumping out blood. This is specifically in patients who have chronic aerobic exercise or high fitness. Moving on to another very important risk factor here in Canada and worldwide is type 2 diabetes. So diabetes, obviously, an increase in blood sugar. In Canada, every 3 minutes, another Canadian is diagnosed with type 2 diabetes. Almost 30% of Canadians are currently living with diabetes or pre-diabetes, which will only increase to about 1/3 of the population by 2025 if the current trends continue. And this is from 2015 data. In 2015, there was about 3.4 million Canadians that are living with diabetes at that time, costing approximately $14 billion per year for the Canadian healthcare system. About 1 in 10 deaths in Canadian adults are attributed to type 2 diabetes. That was back in 2008, 2009, which you can only imagine has increased since then. And again, projections going forward, 2025 is expected that more than 5 million people within Canada will be affected with type 2 diabetes within the next 10 years. And it'll cost another 17.5 billion years overall, $1 billion overall to the Canadian government and the taxpayer. What do we define as diabetes? So the A1C, or the 3-month level of greater than 6.5%, fasting sugar of greater than 7, or a 2-hour test of greater than 11.1. Why do we care about diabetes? This is definitely not your wheel of fortune. I would definitely call it more of a wheel of misfortune. Many different potential end organ damage potentially done by type 2 diabetes. So again, specifically looking at blood vessels, blockage of blood vessels to the brain causing a stroke, blockage of blood vessels to the heart causing a heart attack, and blockage of blood vessels elsewhere to the hands and legs causing issues with pains or peripheral arterial disease. Within the eyes, as I'm sure you've all heard, causing blindness as a result of glaucoma, cataract, as well as diabetic retinopathy, or growth of irregular or improper blood vessels within the eye as a result of type 2 diabetes. The common or more realizable things that we see in the public with diabetes, so diabetic foot ulcers due to a lack of sensation from peripheral neuropathy or the death of the nerves within our feet, eventually leading potentially to amputation. So I mean, diabetes in general is bad news and is something that we should all try to avoid as much as possible. What do we know in terms of exercise and our blood sugar? We've had numerous different trials that are looking at blood sugar levels and exercise. All of them have shown a significant reduction in your 3-month average or your hemoglobin A1C with both resistance training, aerobic training, as well as combined programs. Out of the 3 listed here, the combined programs have the best benefit in terms of reducing your 3-month average or your A1C. If you have regular combined programs, including both resistance or weight training, as well as cardiovascular activity or aerobic training, you can actually reduce your blood sugar by about 0.25 to 1% overall. Again, that's over a 3-month average. Looking at people who have established type 2 diabetes, so this is a study from 2012, we know that moderate exercise has definite benefit in this patient population. In terms of total mortality, so all-cause mortality, a 40% reduction in people with type 2 diabetes who exercised regularly, and a 50% reduction in cardiovascular mortality. So, I mean, literally a half reduction in your cardiovascular mortality if you're diabetic who exercises regularly, which, I mean, in terms of reduction of mortality, it would be very rare. And I know for a fact that in terms of mortality reduction, you're not going to get numbers like this with medication. So, I mean, it's something that is, again, potentially low-hanging fruit depending on your comorbidities and your physical ability, but it's something that could really benefit you above and beyond taking your pills on a regular basis. When looking at people with diabetics with low physical activity versus high physical activity, again, this study from 2012 of, again, approximately 5,000 patients found that there was a 60% reduction in both cardiovascular as well as all-cause mortality. Again, numbers that you will not see, generally speaking, with any sort of medication or medical therapy that we have available to us currently. Moving on specifically to exercise and the heart. So when I talk about the heart, I talk about different systems within the heart. I generally will compare the heart just like a house has a plumbing system, a structural system, and an electrical system. Specifically for today, I'll talk about the plumbing system, i.e. the coronary artery disease or blockages within the blood vessels. And I'll also talk about the structural system and heart failure. Starting off with coronary artery disease, so there's a spectrum of heart disease, starting off at asymptomatic blockages that likely the majority of the population has and are not really known to us. This can progress to a level where there's actual significant blood vessel blockage, causing chest pain as a result of lack of blood flow. This is similar to having pain in your bicep, for example, from doing bicep curls, or in your legs if you're doing a very long bike ride. If you're having a lack of oxygen, you will get pain because of an acid buildup. This is the same thing that happens with angina. A heart attack, on the flip side of things, is essentially where you have a stable plaque which has a fissure or a rupture, causing a blood clot to form, which is an acute event, generally speaking, happening within minutes to hours, which will alert us to probably get to the hospital as soon as possible to have the angiographers or our plumbers, pictured down here, to open up the blockage. Heart disease is the second leading cause of death amongst Canadians. About 1 in 12, or 2.4 million Canadians above the age of 20 are known to have blockages. Every hour, about 12 Canadian adults are diagnosed with coronary artery disease or heart disease, and they die. Death is approximately 3 times higher in adults ages greater than 20 with heart disease. 4 times higher in patients above the age of 20 who have had a prior heart attack, and 6 times higher in patients who are diagnosed with heart failure. It affects men and women differently. Men are 2 times more likely to suffer a heart attack as compared to women. And men with newly diagnosed heart disease are, generally speaking, a lot younger, or about 10 years younger than women. So, that being said, can exercise actually prevent the incidence of these blockages or coronary artery disease? The Intraheart study was one of the big studies that I learned about as a fellow. So this was actually by a Canadian-led study out of McMaster with Dr. Salem Youssef. This was published in a rather large medical journal called The Lancet in 2004. So this looked at 52 countries, 30,000 patients, so a pretty big scope worldwide. Looking at physical activity and sedentary lifestyle, as well as other risk factors. What this study essentially found was that regular physical activity actually reduced your risk of having a heart attack by about 14%. So these are patients who do not have a known history of blockages or heart disease. Other than that, I mean, generally speaking, these effects were found in all groups. So it did not matter whether you were a man or a woman, whether you were older or younger, age cutoff of 65 for this study, and which part of the world. So, I mean, did not matter whether you were from Africa, Southeast Asia, America, or elsewhere. The benefits were pretty much uniform across the board here. Looking at the National Health and Nutrition Database, this is from the US. So this was a study looked at about 10,000 Americans, which were followed up to about 19 years in total. And they looked at cardiovascular survival in patients who did and did not exercise with known cardiovascular risk factors. So this again would be type 2 diabetes, hypertension, issues with their cholesterol or otherwise, smoking, etc. And what this found, and which can be seen pretty clearly, is that patients who were inactive had the lowest survival. People who had moderate activity and light activity had a significantly higher survival as compared to those with inactive. The difference between light and moderate in this graph specifically, which is probably not really shown very well, was not statistically significant. But generally speaking, the big factor being, if you're completely inactive versus having even a little bit of physical activity, your general survival with known cardiovascular risk factors was quite a bit better if you were active. Again, not to beat a dead horse, but this was a study of 5,000 males from the US, which were followed for, again, about 20 years. As you can see, pretty obvious here. So people with inactive lifestyles had a higher event rate per 1,000 years as compared to those with moderate or moderate to vigorous exercise. And again, this was American patients, so and it was purely just males. Relatively limited study, but again, shows a pretty basic trend which can be seen across the board. So what about for patients who have known blockages or known coronary artery disease? What does cardiac rehabilitation specifically do for these people? So what do I mean by cardiac rehabilitation? So this is one of, again, my couple of hats that I have in my clinical practice. So cardiac rehabilitation is actually a comprehensive program which is designed for patients with a multitude of cardiac problems. So again, splitting it up, whether you have issues with the plumbing system, so blockages within the heart vessels, whether you have issues with the pump itself or structural problems, i.e. heart failure, or whether you have issues with the electrical system or the valves, cardiac rehabilitation is generally geared for all of those patient populations. And I'll touch a little bit more on this as what we do locally later in the presentation. The components of cardiac rehab are not just exercise. So, I mean, we have an assessment session where we do a medical as well as a physical assessment. Throughout the program, the 16 weeks that we have here, we do risk factor management as well as educational sessions for all the patients. Psychosocial counseling, as we know, mental health plays a huge part in terms of cardiovascular health. And then finally, again, what we're talking about today, physical activity counseling, as well as exercise training within the program itself. So cardiac rehabilitation in patients who have known heart disease, specifically, so this was a study of, again, 15,000 patients published in 2016 in one of our big papers, the Journal of American Cardiovascular Conditions. What this essentially looked at was patients who had a history of either a revascularization procedure, so either a bypass surgery or an open heart surgery, or a stenting procedure, or have had a heart attack of some sort or another. And what this found was essentially patients within this population who underwent a cardiac rehab program, again, consisting of all of those different factions that I mentioned. What they found was essentially a 25% or 26% reduction in cardiovascular death, as well as roughly a 1/5 reduction in cardiac hospitalization, having gone through a traditional 16-week program involving all of those different factors for cardiac rehabilitation. So heart failure, again, looking at the pump function of the heart and cardiac rehabilitation, so a multimodality system to try to help with that. Heart failure comes in two different varieties. So the more commonly known variety is systolic heart failure, or people who have a baggy or a dilated heart or a weakened heart muscle. In this setting, people will have issues with pushing blood forward to supply the needs of the body, both on the left side as well as potentially on the right side, causing various different symptoms, including shortness of breath, fatigue, swelling, abdominal bloating, and otherwise. Generally speaking, these are the same symptoms that we see with people who have diastolic heart failure as well. So these people actually have a normal pump function. However, for one reason or another, we'll have a thickened muscle of the heart, causing not necessarily issues with pumping the blood out, but actually receiving the blood to fill the heart chambers itself, i.e. causing stiff ventricle walls. So, in terms of heart failure in general, it is very present within Canada. It's on the rise. Approximately 600,000 Canadians are currently living with heart failure. 50,000 Canadians each year are diagnosed with heart failure, whether that be systolic or the weakened heart muscle, or diastolic or the stiffened heart muscle. Out of that, about 1 in 2 Canadians are touched with heart failure. So whether you yourself are affected with it, or whether you know someone who is a loved one or a friend or a family member who has heart failure, approximately 50% of Canada is affected by it. Heart failure costs the Canadian government approximately $2.8 billion per year. So definitely not anything to bat your eye at. The exercise limitation in heart failure is not only as a result of the improper functioning of the heart muscle itself, but also because of skeletal muscles, so your muscles within the body. And with that, due to inactivity, muscle atrophy or loss of your muscle bulk, inefficient use of your energy resources or your ATP within the body, and a more rapid accumulation of acid. Again, as I mentioned previously in this presentation, generally speaking, what's going to limit your muscle function is lactic acid buildup and acidosis and pain as a result of that in the setting of isometric exercise. And people with heart failure, as a result of not being able to clear the acid, are going to accumulate the acid a lot more quickly. Muscle weakness, generally speaking, can affect all of the muscles of the body. This includes the respiratory muscles or the breathing muscles, which can increase your sensation of having shortness of breath while exerting yourself. When looking at this in studies, when looking at approximately 20,000 patients followed for approximately 5 years, what our researchers have shown is that there's no change in terms of mortality up to 1 year after entering one of these cardiac rehab programs. After about a year of regular exercise, there is a trend towards a reduction in all-cause mortality, approximately 12% reduction in all-cause mortality if people are to continue on with a regular exercise program. Also, hospitalization, a very important metric for patients' quality of life, as well as for the general healthcare system. There was an obvious reduction up to 1 year after having undergone a cardiac rehab program. Unfortunately, not carrying on after that time resulted in the loss of that. Quality of life. So this is judged by various different questionnaires that we have for patients involving their general day-to-day mood, as well as their ability to do the function of their tasks that they need to do on a day-to-day basis. This has been improved across the board in patients with heart failure who have undergone cardiac rehabilitation. Finally, finishing off with what we have available here. So cardiac rehab, obviously, as you guys know, we have available here at the Reh-Fit Center. On the other side of the city, we also have it available at the Wellness. Here at the Reh-Fit Center, just throwing out a plug to Dr. Myman, one of my mentors. He was the driving force in terms of developing the Reh-Fit Center. He was the medical director for cardiac rehab in 1979, eventually developing the Reh-Fit Center at that time from a small 250 square foot room at the St. Boniface Stress Lab to this very beautiful center that you guys see currently. So again, I'm sure all of you guys have been. The Reh-Fit Center is the center of excellence in terms of cardiac rehab across the country. We have, again, quite a bit of facilities in terms of weight training or isometrics, as well as cardiovascular training, as well as group sessions. Currently within the program here, the physicians involved are both internal medicine, cardiology, as well as, I believe, one emergency physician. We have very dedicated nursing staff, kinesiologists, as well as support staff. Our program consists of, again, an intake where you have both a medical assessment as well as a physical assessment, and then the 4-month program where you get all of the education, the psychosocial support, risk factor management, and then finally an exit, which involves, again, a stress test, which happens at intake, just to compare what your fitness is at and just to see whether or not we've reached our goals in terms of achieving risk factor reduction and general prevention goals that we have for all of our respective patients. Indications are many. So again, I've specifically only talked about the plumbing system and the pump function, so heart failure and coronary disease. I didn't really touch on the electrical system or arrhythmia, congenital heart disease, or again, things that people are born with, valve disease or problems with the doors and windows of the heart, as well as other conditions such as peripheral arterial disease or blockages within the arms or legs that might cause problems. We see all kinds of patients within the scope here at the Reh-Fit Center as well as at the wellness. In conclusion, so a sedentary lifestyle, as we see, has been shown to increase the risk of numerous conditions, including cancer, the #1 killer worldwide, as well as cardiovascular disease, the #2 killer. Exercise specifically has been shown to be beneficial in the improvement of cardiovascular risk factors, including hypertension and diabetes. And cardiac rehabilitation has specifically helped the reduction in cardiovascular events and the quality of life in patients with numerous different cardiac ailments, including coronary disease, heart failure, and otherwise. Any questions?
Thanks, Rob. Oh, there's someone in the chat here. Will the effect of a year of reduced activity due to COVID-19 restrictions be permanent, or can it be reversed by becoming more active?
That's a very good question. So, I mean, generally speaking, 1 year of having decreased exercise in the lifespan of, generally speaking, within Canada of up to 60 to 80 years, one would think that, 1 year of having physical inactivity is not going to have a huge effect. I have that same sort of, approach to patients within the lipid clinic that I deal with. So cholesterol is sort of the same thing as hypertension, type 2 diabetes, physical inactivity. These are chronic risk factors. So again, for physical inactivity, if you were to compare it to, say, type 2 diabetes or cholesterol, it's going to be a lifelong risk. For cholesterol, specifically bathing your blood vessels in a high cholesterol for say a year, for not taking medications, as compared to having high blood cholesterol for say 10, 15, 20 years, your chances of developing a blockage and potentially having an effect in terms of having an event or a heart attack or stroke, etc., are quite a bit higher if you're chronically uncontrolled. I would say the same is with physical inactivity and lack of exercise.
So I'll just put it out there. I don't think Dr. Singh's an exercise specialist, but there is a question about kind of, would you recommend different exercises for people with arthritis or any kind of restriction? So I guess, do you have people that come to your clinic that maybe have coronary artery disease and they are limited? What suggestions do you have, or do you recommend them to, other health exercise professionals?
For sure. So, I mean, again, anytime we have, patients coming in for cardiac rehab or general, physical assessment and starting out an exercise program, we do a full medical assessment as well as a physical assessment. So we would never, encourage people to undergo exercise which may potentially harm them for other aspects of their life, including arthritis. So, I mean, if someone is limited, in doing a certain exercise, say if they have arthritis of their lower limbs, knee or hip or osteoarthritis, we would generally recommend exercises that would not cause increased stress on those. So, I mean, if you're not able to do, say, a treadmill or an elliptical, recommending something like a recumbent bike, or something of a lower stress, to the joints themselves. Again, it's not specifically the activity itself, but more so sort of getting into that moderate range and getting the appropriate time. So that 150 minutes per week would be the big thing. So not necessarily the actual activity itself.
Great. One other question, Rob. What can be done with the plaque already built up inside the blood vessels?
Yeah, so unfortunately, we have not found a drano as of yet for the blood vessels. The plaque, once it's there, it's there. There's not much we can do to get rid of it at that point. With cholesterol medication, there has been some very minor regression in terms of the plaque. Generally speaking, once we know we have plaque, the biggest thing is to try to stabilize that plaque and make sure that it doesn't increase in size. And also in terms of stabilization of plaque, I didn't mention it within the coronary disease section of this talk itself, but a lot of plaque actually has a very thick fibrous cap. So, blockages of 40, 50, 60% and above have built over a number of years. And in that time, of course, they've also developed a very thick cap. With that thick cap, it's a lot less likely to rupture and actually cause an event like a heart attack, which can actually reduce, your overall longevity. So I mean, things that will increase the cap thickness will be things like compliance to medications, specifically medications for cholesterol or your statins, which will decrease the cholesterol levels within the blood, and B, we know actually stabilize the plaques themselves, so they're less likely to rupture. In addition to that, in terms of getting rid of plaque, again, not much that we can do, but traditional risk factors, so controlling your blood sugars, which will cause less of a chance of causing those plaques to be unstable. Controlling your blood pressure. So again, if you can think of turbulence of blood flow, the higher the blood flow or the more the pressure, the more likely that one of these caps is going to be disturbed and cause an issue. So all of those typical sort of risk factors that I talked about, controlling those will generally be your best bet. But again, unfortunately, we don't have any miracle cure to actually get rid of the plaque itself.
One more question here. I've started wearing a Fitbit. It measures my number of steps taken during the day and my active minutes. After listening to presentation, active minutes is more important than steps, correct? Is it more important to exercise? It is more important. Sorry.
So, I mean, both are important. So, I mean, steps is, again, one of those things that obviously wasn't a very practical metric for us to measure prior to technology advancing and iPhones and Fitbits and watches and things like that. So there's a great number of studies which look at steps per day in terms of your fitness. So, I mean, the general target that we have for the population is getting 10,000 steps per day. If you're doing that, that's great. And that's been shown to definitely improve overall health and mortality benefit as well. In addition to a variety of other benefits in terms of traditional risk factors. Fitness and exercise is a little bit different. So again, what I say to my patients is, even though, say, if you do have a very active job, so if you're doing manual labor, or if you're, say, a foreman or something where you're walking, say the 10,000 steps, fitness as composed or exercise as compared to physical activity is a little bit different. So that's an actual structured activity that we have outside of just our day-to-day 10,000 steps that we may get. And we know, again, from the studies that I showed today, that, getting that additional specific dedicated activity actually has additional benefits outside of just being an active person. Again, obviously being a sedentary person is probably the worst thing that you can do.
Lots of questions for you tonight. One more. How do I know the amount of exercise is due? Is light, moderate, or moderately vigorous? So asking about intensity.
Good question. So, I mean, Googling specific types of physical activities and exercise, you can get charts of what exactly a moderate versus a light versus strenuous exercise is. Keeping it more simple. So, I mean, moderate activity would be anything between 60 to 80% of your maximal heart rate. A person's maximal heart rate, just as a rough ballpark, we calculate as 220 minus your age. So, I mean, 60 to 80% of that. An even easier measure that I use is, if you're doing an exercise, you should be able to carry on a conversation, but not sing at the top of your lungs. So, I mean, if you're walking vigorously, or if you're jogging, doing an elliptical, you shouldn't be going so hard that you're not able to at least carry on a basic conversation. But at the same point, you shouldn't be able to sing along with the music that's going on in the gym as well, right? So that's sort of a basic.
Great. I think a lot of the fitness staff can help you out with those questions as well, Stan. If you're not sure about intensity, I would encourage you to talk to some of the staff that are on the floor, and they can help you out. So I'll just wait a couple more seconds. I don't see any other questions popping up, but all really good questions everybody asked, and great answers. Again, thanks for that. That was a great presentation. I will just take a look at the time, but I think we're pretty good. So I will say goodnight to everybody. We have another great presentation on Thursday. Of course I blank at this exact moment. It'll be up on social media, but it's been a good one and we've had a lot of good series. And so I will say good evening to everybody. And thanks again, Rob, for helping us out.
No problem. My pleasure. Thanks, everybody.
Okay. Thanks.